Hello guys, welcome to another session of Diabetes Mellitus, and in this session we will be discussing about the drugs that are used for the treatment of diabetes mellitus, mainly anti-diabetic drugs. We'll first see what are the learning objectives of this session. At the end of the session, the student should understand the mechanism of action of various anti-diabetic agents, and he should understand the individual anti-diabetic drugs and also the treatment algorithm for type 2 diabetes mellitus. Diabetes mellitus is a condition in which there is reduced insulin secretion, there is reduced action of insulin, or there is a combination of both these things. So normally what insulin does is that it will move glucose from plasma to tissues. When insulin is reduced or when insulin is not acting properly, this will result in increased glucose in plasma. That is one of the important feature of diabetes mellitus. So the agents used for the treatment of diabetes mellitus, they will reduce the plasma glucose in one way or the other. So the anti-diabetic drugs, they can be broadly classified into 4 different classes depending upon their mechanism of action. The most important mechanism of action of anti-diabetic agent is by increasing insulin secretion, and there are certain agents that will increase insulin secretion. And the second mechanism of action of anti-diabetic agent is those agents that reduce insulin resistance. Insulin resistance is a condition in which insulin is present in the body, but binding of insulin to receptors does not produce any response. And the third mechanism of action of anti-diabetic agent is by reducing the glucose reabsorption from the kidneys. And the fourth mechanism is those agents that reduce the absorption of glucose from the gastrointestinal tract. So first we will discuss about the agents that will increase insulin secretion. 4 groups of agents increase insulin secretion. The most commonly used agent among the agents that increase insulin secretion are sulfonylureas. And an example is glycemic. Okay. And the second group of agents that increase insulin secretion is meglitinide analogues. Example is repaglinide. And the third group of agent that increase insulin secretion is SGLT1 agonist. Example is exenatide. And the fourth group of agents that increase insulin secretion is dipeptidyl peptidase 4 inhibitors. Example is sitagliptin. Okay. So first we will discuss about all these agents in detail, and first we will discuss about sulfonylureas. So 3 sulfonylureas are commonly used in clinical practice. They are glipizide, glimepiride, and glyburide. How these sulfonylureas increase the insulin secretion? So normally in the beta cells of the pancreas, there are potassium channels in the cell membrane, and these potassium channels will move the potassium from the intracellular to the extracellular, and this will result in a state of hyperpolarization. And this hyperpolarization will inhibit insulin secretion. Okay. Inward movement of positively charged ions or inhibition of these potassium channels can result in depolarization, and this will result in insulin secretion. So what the sulfonylureas do is that they will inhibit these potassium channels, and this will result in reduced outward movement of potassium. So potassium accumulates inside the cell, and this will result in development of a positive charge intracellularly, and this will produce depolarization. And depolarization will trigger the release of insulin. There are other mechanisms of action of sulfonylureas as well. Sulfonylureas, when they are administered for long duration of time, it will increase the sensitivity of tissues to insulin. So when the sensitivity of the tissues are increased, this will result in increased action of insulin, and that will result in increased movement of glucose from the plasma into tissues. So the mechanism of action of sulfonylureas is by increasing the insulin secretion. So when insulin secretion increases, it can produce reduction in plasma glucose. So this can produce hypoglycemia. So one thing you have to remember about sulfonylurea is that sulfonylureas will stimulate insulin secretion even when the plasma glucose is low. So the stimulation of insulin secretion with sulfonylureas is not dependent upon the plasma levels of glucose. So a person who is having low plasma glucose, if he is taking sulfonylureas, he will definitely develop hypoglycemia. So that is one major drawback of this sulfonylurea. Another disadvantage of sulfonylurea is that since insulin is an anabolic hormone and insulin secretion is increased by sulfonylureas, this use of sulfonylureas can produce weight gain. Sulfonylureas reduce the HbA1c by 1 to 2%. So when you are learning about anti-diabetic agents, this is the most important thing that you should remember. How much HbA1c is reduced by each group of drugs. So you will be able to understand how much efficacious each of the drug is. One important advantage of sulfonylurea is that it is very cheap and it is available everywhere. Okay. Next group of agents that increase insulin secretion is meglitinide analogues. Two meglitinide analogues are available in the market. They are repaglinide and natiglinide. So you don't have to remember much about this meglitinide analogues because they are exactly similar to that of sulfonylureas. Only thing different is their chemical structure. So if you learn sulfonylureas, you will be able to know meglitinide analogues. So the next group of agents that increase insulin secretion are SGLT1 agonists. So they mimic the incretin hormone glucagon-like peptide 1. And 4 agents are available in the market now: exenatide, liraglutide, dulaglutide and lixisenatide. Okay. So before we go into the mechanism of action of GLP-1 agonist, we should understand what these incretins do in our body. The beta cells of the pancreas contains receptors for incretins. Okay. So they have receptors for GLP-1 and also for GIP. So binding of these incretins to the beta cells of the pancreas will result in increased levels of intracellular cyclic AMP. And when the intracellular cyclic AMP levels are increased, this will result in blockade of the potassium channels which are present in the plasma membrane of the beta cells of the pancreas. So this will reduce the outward movement of potassium. So when potassium channels are blocked, the intracellular positive charge will increase and this will result in depolarization. And depolarization will trigger the release of insulin. GLP-1 agonists also have other actions other than increase in insulin secretion. They reduce the peristalsis. So food stays in the gastrointestinal tract for longer duration of time. They also reduce the appetite. So by reducing the gastrointestinal movements and also by reducing the appetite, GLP-1 agonist produces weight loss. So, unlike sulfonylureas, GLP-1 agonist stimulate insulin secretion only when glucose is present in sufficient quantity in the plasma. Sulfonylureas will stimulate insulin secretion even if the plasma glucose levels are low. So that can produce hypoglycemia. Whereas this GLP-1 agonist, they will stimulate insulin secretion only when the plasma glucose levels are sufficient. So it does not produce any hypoglycemia at all. So that is one advantage of this GLP-1 agonist compared to that of sulfonylureas. The major disadvantage of GLP-1 agonist is that they are given as injections, subcutaneous injections. So a person who is having diabetes mellitus, he might need to take treatment for his lifespan. So nobody would be very keen on getting injected every day with GLP-1 agonist or any other injection. GLP-1 agonists reduce the glycated hemoglobin by 1%. The major adverse drug reactions of GLP-1 agonists are, one is nausea and vomiting. The major adverse drug reactions are gastrointestinal. It can produce nausea and vomiting. It can also produce pancreatitis. So these are the major adverse drug reactions of GLP-1 agonists. Another major disadvantage of GLP-1 agonists is that they are expensive. They are relatively new to the market, so they are expensive. The fourth group of agents that increase insulin secretion is DPP-4 inhibitors. Many DPP-4 inhibitors are available in the market. We will be discussing mainly about three agents. One is sitagliptin, second one is vildagliptin, and the third one is teneligliptin. So DPP-4 is an enzyme that metabolizes incretins. So increased levels of incretins will increase the action of incretins in the beta cells of the pancreas, and that will stimulate insulin release. So the insulin released is increased by at least twofold. And compared to sulfonylureas, this DPP-4 inhibitors do not stimulate insulin secretion even when the plasma glucose is low. So this does not produce significant hypoglycemia. DPP-4 inhibitors, they reduce the glycated hemoglobin by 0.5 to 0.8%. And the major adverse drug reactions associated with DPP-4 inhibitors is that it will produce joint pain. And it also produces nasopharyngitis. So that concludes the agents that increase the insulin secretion. The agents that increase the insulin secretion are sulfonylureas, meglitinide analogues, GLP-1 agonists, and DPP-4 inhibitors. So coming to the next mechanism of action of anti-diabetic drugs, that is reducing insulin resistance. Two agents are available in the market that can reduce insulin resistance. These agents are metformin and pioglitazone. So the synthesis of glucose from fats and amino acids is known as gluconeogenesis. So this is a normal process that happens in our body when we are fasting or when we are deficient in energy. So this process requires ATP, and in the presence of ATP only this gluconeogenesis takes place. So metformin, what it does is that it will inhibit the ATP production, thereby reducing gluconeogenesis. Gluconeogenesis is also inhibited by an enzyme called as AMP kinase or AMPK. Metformin will stimulate this AMP kinase enzyme and that will reduce gluconeogenesis. And metformin also reduces the absorption of glucose from the gastrointestinal tract, thereby reducing the glucose that reaches the plasma. Metformin also has an action of reducing the appetite, and this action is achieved by increasing the levels of GLP-1. As you remember, GLP-1 reduces the peristalsis and also reduces the appetite. So, because of this, metformin can produce loss of appetite. Metformin also increases the sensitivity of tissues to insulin. So, when tissues are more sensitive to insulin, more amount of glucose will enter inside the cell. Glucose will be moved from the plasma into the tissues, that will result in reduction in plasma glucose. When you are using metformin, it will reduce the complications associated with diabetes mellitus. So diabetes mellitus is a disease which has got many complications, both microvascular complications and also macrovascular complications. And using metformin can reduce all these complications. This is one important thing that you should remember about metformin. Metformin is the first line drug for the treatment of diabetes mellitus, especially type 2 diabetes mellitus. And it is the drug of choice for starting treatment of type 2 diabetes mellitus unless otherwise contraindicated. And one important advantage of metformin is that we have been using metformin for a long duration of time, and metformin is very cheap. And since metformin does not increase insulin secretion, it does not produce hypoglycemia. And metformin, by increasing the levels of GLP-1, it reduces the appetite, and that will result in weight loss. So this is a suitable agent for patients who are obese and diabetic. The usual dose of metformin is 0.5 to 2 grams per day. Beyond 2 grams, metformin does not produce any considerable reduction in plasma glucose. Metformin is also used off-label because it is not an approved indication for a condition known as polycystic ovarian syndrome. Okay. Polycystic ovarian syndrome is a condition that develops due to insulin resistance. So metformin reduces this insulin resistance and thereby produces improvement in polycystic ovarian disease. The major adverse drug reactions of metformin are very mild. It produces gastrointestinal adverse drug reactions like nausea and vomiting. Metformin also produces bloating. Long-term use of metformin can reduce the absorption of vitamin B12, and that can result in B12 deficiency. Metformin also increases the amount of lactic acid in the plasma, that can result in lactic acidosis. This is a very important adverse drug reaction of metformin, and you should be very aware that metformin can produce lactic acidosis. Okay. Metformin reduces the glycated hemoglobin by 1 to 2%. The next agent that reduces insulin resistance is pioglitazone. Adipose tissue, skeletal muscles, and liver contains a type of receptors known as PPAR gamma. So this is an abbreviation for peroxisome proliferator activator receptor gamma. So stimulation of these receptors will result in increased movement of glucose from the plasma into these tissues. So pioglitazone will stimulate these receptors, thereby increasing the uptake of glucose by skeletal muscles, adipose tissue, and also liver. And by increasing the uptake of glucose by these tissue, pioglitazone will reduce insulin resistance. The synthesis of glucose from fats and amino acids is known as gluconeogenesis. Pioglitazone inhibits this gluconeogenesis, thereby reducing the plasma glucose. Pioglitazone also has got a favorable effect on plasma lipids. It will increase the plasma HDL level, which is a good cholesterol. Pioglitazone reduces the glycated hemoglobin by 0.5 to 1.4%. Pioglitazone can produce weight gain. This is by causing fluid retention. Fluid retention will result in increased accumulation of fluid inside the body, and that will result in increase in weight. Pioglitazone can also precipitate cardiac failure, especially in patients who are having pre-existing cardiac conditions. Long-term use of pioglitazone is also associated with bone fractures. So that's all about the agents that reduce insulin resistance. Two agents are available in the market. One is metformin and the other one is pioglitazone. Metformin is the first line agent for treatment of all the patients who are having type 2 diabetes mellitus unless contraindicated. So third group of agents that are used for the treatment of diabetes mellitus, these agents will reduce the glucose reabsorption from the kidneys. Normally, the glucose present in plasma will be filtered by the glomerulus and they will go through the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting tubule. So in the proximal convoluted tubule, there are transporters that will transport sodium and glucose into the cell, and from there this will be reabsorbed. And this transporter is known as sodium glucose cotransporter 2 or SGLT2. So the agents that reduce glucose reabsorption will inhibit this transporter. So this will reduce the reabsorption of sodium and also the reabsorption of glucose. So this will result in increased excretion of glucose through urine. So these agents, they are called as SGLT2 inhibitors or sodium glucose cotransporter 2 inhibitors. Three agents are available in the market: canagliflozin, empagliflozin, and dapagliflozin. These three agents are used for the treatment of type 2 diabetes mellitus. These agents reduce the glycated hemoglobin by 0.7 to 1%. SGLT2 inhibitors can produce mild reduction in weight due to loss of fluid. Since it does not increase the secretion of insulin, it does not produce hypoglycemia. So the major drawback of this SGLT2 inhibitors is that more amount of glucose is excreted through the urinary tract. So it can result in urinary tract infections. when more amount of glucose is present in the urine, that will be a very good medium for organisms to grow. So that will result in urinary tract infection. And since more amount of glucose is excreted through the urine, this urine will obviously come into contact with the genital, so it can result in genital tract infections as well. Long-term use of SGLT2 inhibitors can produce bone fractures. The disadvantage of SGLT2 inhibitors is that they are very expensive. They are comparatively new to the market, so they are expensive. Okay. So that's about the agents that reduce reabsorption of glucose from the kidneys. So 3 agents are available: dapagliflozin, empagliflozin and canagliflozin. They are expensive and they produce urinary tract infections and also genital tract infections. So the last group of agents that are used for the treatment of diabetes mellitus are the agents that reduce absorption of glucose from the gastrointestinal tract. So the complex carbohydrates that are present in the diet will be broken down into simple carbohydrates by an enzyme called as alpha-glucosidase. So this enzyme breaks down the complex carbohydrates into simple carbohydrates so that it can be absorbed into the systemic circulation. So the agents that reduce gastrointestinal absorption of glucose will inhibit this enzyme alpha-glucosidase, thereby reducing the gastrointestinal absorption of carbohydrates. 3 alpha-glucosidase inhibitors are available in the market. They are acarbose, meglitinide and voglibose. So this is the basic mechanism of action of alpha-glucosidase inhibitors. Alpha-glucosidase inhibitors also increase the levels of GLP-1, which is the incretin, glucagon-like peptide 1. Normally, glucagon-like peptide 1 will stimulate insulin secretion. So increased levels of GLP-1 will increase the insulin secretion. That is another mechanism of action of this alpha-glucosidase inhibitors. Since alpha-glucosidase inhibitors inhibit the absorption of complex carbohydrate, this will be acted upon by the gut microflora and that can result in flatulence. And due to the buildup of gas in the gastrointestinal tract, it can also produce bloating. Okay. Alpha-glucosidase inhibitors reduce the glycated hemoglobin by 0.5 to 0.8%. They are not used regularly for the treatment of type 2 diabetes mellitus. They are mainly used for the control of postprandial hyperglycemia. Okay. So the agents that reduce gastrointestinal absorption of carbohydrates or glucose, they inhibit the enzyme that breaks down complex carbohydrates into simple carbohydrates. So 3 agents are available: acarbose, meglitinide and voglibose. All these agents will inhibit the alpha-glucosidase enzyme. Since this complex carbohydrates are not broken down, this will be acted upon by the intestinal microflora and that will result in development of flatulence and bloating. So these are the anti-diabetic agents that are used for the treatment of type 2 diabetes mellitus. So now we will see how to manage a patient who is newly detected with type 2 diabetes mellitus. So a person who is coming with type 2 diabetes mellitus, the assessment of his glycemic control should be based on HbA1c. So if he is detected to have diabetes mellitus, what all things you should be doing? First, you should give an education regarding diabetes mellitus. You should also make him understand what is the importance of nutrition. And you should also make him understand what is the importance of physical activity. And at the same time, you should also screen for complications. diabetes has got large number of complications, micro and macrovascular complications. The major complications are retinopathy, nephropathy, and neuropathy. So you will have to do retinal examination, and you have to check renal failure by checking the levels of albumin in urine. You have to check for neuropathy, and you have to check for also cardiovascular evaluation. Check for other comorbidities which are associated with type 2 diabetes mellitus, like dyslipidemia, hypertension, obesity, and cardiovascular disease. If these diseases are present, you have to treat them as well. And you have to start the person on metformin since he is having type 2 diabetes mellitus, and metformin is the first line agent for the treatment of type 2 diabetes mellitus. You have to start him on metformin. After you start treatment with metformin, you will have to reassess the HbA1c after 3 months or 6 months to see whether the person is responding to metformin. If the person is not responding to metformin, then you will have to add a second agent. And there is no consensus statement which agent you should start. It should be according to your discretion. It should also be dependent upon the patient's financial status. If the patient is having good glycemic control with metformin, then you should continue metformin. And after adding the second agent, you have to reassess for HbA1c. And if the person is not attaining adequate glycemic control with metformin and the second agent, you have two options. You can add another agent along with metformin and the second agent, or you can switch to insulin along with metformin. And after making this treatment choice, you have to reassess the patient. So our goal of treating a patient with type 2 diabetes mellitus is to keep the HbA1c less than 7. So patients who are having an HbA1c less than 7 will be having less complications associated with type 2 diabetes mellitus. So to summarize, anti-diabetic agents, they are the agents that are used for the treatment of type 2 diabetes mellitus. And metformin is the first line agent for the treatment of type 2 diabetes mellitus unless contraindicated. Another commonly used agent is sulfonylurea. It increases insulin secretion, thereby reducing plasma glucose. But the problem with sulfonylurea is that it will increase insulin secretion invariable of the plasma glucose level. So it can produce hypoglycemia. And you should also remember the newer agents that are used for the treatment of type 2 diabetes mellitus. One is GLP-1 agonists, which act on the GLP-1 receptors in the beta cells of the pancreas, thereby increasing insulin secretion. Then there are DPP-4 inhibitors, which will reduce the breakdown of incretins, thereby insulin secretion. And also agents that reduce the reabsorption of glucose from the kidneys, that is SGLT2 inhibitors. So I hope this session was very useful for you, and this is very important because India has the second largest population of diabetics, and you will come across diabetics on an everyday basis. So remember all these things while you are treating the patient, and also remember all these things when you are going to write the exam also. Thank you.